Thank you, Mike, and I'd just like to thank the organising group for asking me to talk today. I'm going to this isn't going to be a high-powered talk like Andrew's was, so it's going to sort of come down a few notches. But I'm going to talk about haemophilia treatment, prophylaxis, our thinking about how we take things forward nowadays, and look at that dreaded word pharmacokinetics and whether it's actually important or it's just a scary word that people talk about. So these are 6 points that we all know about prophylaxis that we're aiming to do. These are our currently accepted targets. We all accept that it's 1 unit per decilitre is our trough, and anything above that we're achieving good targets and we're stopping bleeding. We're wanting to convert severe disease essentially to moderate, to reduce the hemorrhages, to delay the arthropathy, protect against joint deterioration and improve quality of life. I think that's all pretty obvious in what we're trying to achieve today. And we base our treatment in terms of prophylaxis, in terms of what we do, on this basic assumption that products last about 12 hours and therefore we need to give something in the range of 25 to 40 units per kilo, factor 8, every alternate day or at least 3 times a week. And that's pretty much what we do for everybody. Something in that range every alternate day or 3 times a week. Now the question that I want to pose to you, and the question that has arisen, and we'll discuss why, largely through the advent of extended half-life therapies and the fact that they haven't been quite such a killer blow, one suspects, as extended half-life factor 9s, is this type of one-size-fits-all regime applicable to absolutely everybody? If you're at a desk or if you're retired, is it as applicable to have an alternate day regime? Are your risks the same as if you're a young kid playing football or out on your bike or even at a very marked extreme in Colorado wanting to go snowboarding? So I think you could say clearly one size probably isn't necessarily right for everybody, but it's only recently I think that we've started to think in these terms. If we even hone it down to 2 men with severe haemophilia A of the same age, we can start to think that even in this situation the treatment regimes may not be identical or shouldn't necessarily be identical. If you've got somebody who doesn't do very much and hates venipunctures versus somebody who's really active and actually doesn't mind giving his injections, is it right that the treatment regime for both of them is identical? And I think we've now started to think about this and start to think whether treatment regimes are the same for everybody, or do they need to be the same for everybody, or do they actually start to need to reflect things such as this: personal choice. How does factor concentrate behave in you, and therefore does that influence how you use it in terms of your activity, what your comorbidities might be, what your venous access is like, how old are you, and how much bleeding are you prepared to accept? Now obviously that's a moot point, how much bleeding are you prepared to accept, because I think as treaters we would really want to see none, but some patients are prepared to trade convenience against minor bleeding or bleeding that can be managed very simply. So that is something that I think as treaters we have to bear in mind, even though we may not necessarily subscribe to that vision ourselves. So we've got our patient choices that we might need to think about, but we've also got the fact that products are a bit different. And we've already talked about or alluded to the fact that we have extended half-life therapies now, but PK is going to vary for each product and it's going to potentially be different. And then we've of course got how much we're paying, what's the volume, who's manufacturing it, and so on. But the thing that links these 2 set of variables up is actually the pharmacokinetics. And I think now we're beginning to think about trying to use pharmacokinetics to individualize treatment for patients. Why? This is actually clearance of factor 8 from a population of patients with severe haemophilia A. Now, as you know, clearance is very similar to half-life, but not quite the same. But what you can see here, and the point of this slide, is that there is a huge variation in a population of patients with severe haemophilia A without inhibitors in terms of clearance. And this variation here, in terms of clearance from 1.4 mils per hour per kilo to 7.4, equates to a change in half-life of potentially 8 to 25 hours. Now 12 might be our median, but there is a big range around that, and we need to bear that in mind. Why does this actually matter? Well, if we think about things, let's think about it in a very simple graphical terms. This is our trough that we want to achieve. If we sit below it, we're at risk of bleeding. If we're above it, we're happy. This is what we assume everybody behaves like. Standard half-life. Here is a point at which we obviously need to reinfuse, and that defines our characteristic alternate day or 3 times a week type of approach. Now let's think about what happens if you put in a 25% variation around this point of half-life. Clearly, some people are going to be shorter, and clearly, some people are going to be longer. We've just said it's 25% variation. But that means that within a 25% variation around the mean, our intervals that we need to infuse to achieve our trough levels have changed significantly. So one size arguably doesn't necessarily fit all, because a significant number of people are going to need to be treated more frequently than we assume, or a significant number of people could potentially achieve the same end with less burdensome infusions less frequently. So I think this is the background of why we're beginning to think that one size doesn't fit all, not just because of individuals, but also because of global aspects about different visions of haemophilia care across the globe, whether it's in Western Europe, North America, Africa, Asia, wherever. One size isn't necessarily the be-all and end-all, and I think we're beginning to think now that we should start to personalise treatment or individualise it. So what I'm going to come on to is how we might do this, and does it actually have any sort of rationale? Clearly, when we want to personalise or tailor treatment, we're looking at these 3 different things: reducing our bleeding rate, optimising our intervals, and that optimisation could mean various different things, and I use it very broadly here. Optimisation to minimise treatment use, or optimisation to actually minimise treatment burden. And the 2 things are going to be a bit different in terms of how we affect factor VIII consumption. But those are the sort of 3 key points that are driving what we do. And our ideal combination for our individual is going to be the lowest frequency, potentially, with the lowest dose to keep the bleeding rate as low as possible. Now, let's think about factor VIII levels. Let's think about a low trough level and a high trough level. Let's think about time that we spend below that trough level. We can go from low to high, and I think you can see which way the arrow is going to go if we talk about bleeding. If you have a high trough level and you spend a low amount of time below that level, your bleeding rate will be low. If your trough level is low and you spend a large amount of time below that, your bleeding rate is going to be high. I think that's all fairly straightforward, and we can understand that theoretically from principles that applies. Is there any evidence to show that this works? Well, yes, this is data from ADVATE studies that Peter Collins published years ago. And what you can see here is the probability of a bleed in a year, remaining bleed-free. And here we have time with factor VIII below 1 unit per decilitre. So a large amount of time, a low amount of time. This is 10 and above, and this is 1 to 6 years of age. Basically, what you see is that the probability of bleeding, of remaining bleed-free, goes down as you spend more time at lower levels. So it proves the point what we're saying before. The next thing, though, that I think we're starting to think about, aside from time below various levels, is actually what is the actual level that we want to achieve. on the very first slide I put at 1%. Everything else we always think about 1%, but I'm sure a lot of you have seen this slide before representing factor 8 levels and risk of bleeding across a population. And what we see is that once you get above 1, you get a sharp decline in rates of bleeding. But we also see that it doesn't completely flatten out until you get to higher levels. But the most important thing is that it is a continuum, and that the higher your trough level, the lower your risk of bleeding. So I think we're beginning to think that 1% is a minimum. It's not an optimal approach. Let's think about half-life variation again here, and we've got our trough levels. We've got one patient here, we've got our other patient here with a longer half-life, and we've got our two different points where we would ideally infuse. If we just think about the populations, we can't be sure which patient sits in which group, and so we have an area of uncertainty in terms of optimal treatment. If we now think that we want to push our trough level up because of the slide I showed before, because that may give us better outcomes and better care, our area of uncertainty all of a sudden becomes a lot greater. So what we're doing at the moment is we're trying to deal with both these issues, the trough levels where it is and the individual variation in pharmacokinetics and half-life, but we're treating everybody the same, but we can already see that there is potentially big variation here in the population. Now the next point, having said that within our group of patients we have a big variation, what about outliers? There are other patients that outlie. This is our median. Most people that we've already just talked about lie within this range, but we can see already how that is potentially significant. But then we've got our two outlying groups, who, if we use a standard approach to treatment, are going to not get optimal treatment. This group, because they're not going to be treated frequently enough and potentially get more bleeding and breakthrough bleeding, this group could potentially be managed efficiently with less frequent infusions because they're fortunate enough to have very long half-lives. If we start putting the outliers on this group, we can suddenly see how the range becomes quite huge. So I think this is the sort of perhaps an exaggerated argument, but the principles underlying the fact why we actually need to know more about how factor concentrates behave in our patients to provide the optimal treatment regimes for them, which is going to deliver best bleeding frequency with a minimised, as far as reasonable, treatment burden and containing costs. And we all know containing costs today is very important. So how do we do this? Well, at the moment, if we were going to do it through a clinical approach, we would maintain our minimum. If we find that patients bleed too much, we will adjust the dose, adjust the frequency. We might adjust it around activities. We might consider intensive prophylaxis in special situations, but essentially it's a clinical determination, and that's what most of us do today. And if we do think about personalising that one size won't fit all, this is how we largely approach it empirically. But the question really now, and has been brought about by extended half-life products and the requirement through NHSE, as I'll talk about later, to use extended half-life products with some more knowledge, is actually approaching this by understanding the pharmacokinetics. And I hope you could see here how knowing the pharmacokinetics could allow us to be far more precise and accurate in determining what is the best treatment for our patients. So, is measuring trough level really ideal, or should we actually get some personal PK data? And the types of approaches that we hear about personal PK data are individual PKs analysis and population PK, and I'm just going to explain the difference between the two. First thing, though, to say about PK analysis that gets everybody worried is they think it's very demanding, it's resource hungry, and we need to find better approaches. And that's one of the reasons that the population PK, which I'm going to talk about, has become popular as a potential approach because it is relatively simpler and relatively less resource hungry. Now, what is a full PK analysis? This is just traditional pharmacokinetics as we might understand it. We give an infusion of the product and we measure it at frequent time points over a 48 or 72-hour period, and there is lots of standardization of the time points that have been published by the ISTH SSCs. And then with that data we can work out what the pharmacokinetics are. Now, there are different ways that factor VIII is handled in individuals. There are different models of pharmacokinetics. The one compartment model is where you give a dose, it goes into your major volume of distribution, and then it's eliminated and you get a terminal half-life. If you draw a linear graph, you get a curve. If you log transform it, it becomes a nice straight line. So that's the one compartment model. But not everybody who metabolizes factor VIII in exactly the same way, and there is a two-compartmental model which applies to some people as well. In this one, the model suggests that a dose is given, it goes into a central compartment, that central compartment equilibrates with a peripheral compartment, and you then eliminate from the central compartment. So that's a two-compartment model. Just to say that these compartments are not necessarily physical in us, they are mathematical compartments, so they're not necessarily physical. But what you get here on a linear scale is a decay curve, which is quite hard to say that's very different from the other. But if you do a log linear curve, you get a straightish line, but it's got a kink in it. And it's got a kink in it because of the change from the two decays, the initial distribution between V1 and V2, and then the terminal elimination from the V2 compartment. And there is also a third approach, the so-called non-compartmental model, which I have no idea what it means, but it means that it doesn't fit to the other two. So, how relevant are these models? This is data from actually some NUVIC, GINA21 study, 66 patients, all individual PKs had their half-lives calculated. And we've got three different colours here. We've got grey for the two-compartment model, yellow for the one-compartmental model, and we've got brown for the non-compartmental model. And basically what you can see is that there is a scatter of these models right across the population. And we see that there is quite a notable distribution of these different models. So there are a lot of two compartments, there are a lot of one compartments, and there are a few no compartments. But there is no consistent pattern here that suggests a particular group at a particular half-life have a particular propensity for a particular pattern. Now, that is how you do individual PK, and you could argue that's very personal, it's very individual, and it's very precise because you are modelling it and fixing it to the individual data and measuring plenty of data. But you can imagine that's a huge hassle. So a lot of work, it's very time consuming, it's a big effort. So there has been a drive to population pharmacokinetics. What is population pharmacokinetics? Population pharmacokinetics is where you try to take all that type of individual data and model it down into a single model algorithm, which is then applicable to a population. So this is the type of response you might get if you gave an intravenous infusion and you gave it to various different individuals, and you can see they're not all the same. There is some variation. In actual fact, this is some data about an intravenous antibiotic given to horses, so it's not actually human at all. But what you can do, and this is factor VIII, is resolve these data into time points, and then you can produce a model, an algorithm that best fits all this data. And this is the basis of the population PK, an algorithm to fit the data of the population that is a best fit. And so we can draw our curve. Now the advantage of this, because it's based on a population, is that if we infuse concentrate into a patient and measure a few time points, as long as we know the time from the infusion, we can work out the difference from the mean of the standard curve. And from that, you can work out what the individual's curve might be and therefore get an estimation of their pharmacokinetics. And you can do it on far fewer blood tests after the infusion. And you can, in fact, also do it if patients are being regularly treated on different infusions. So it becomes very, very much simpler. This slide really is just to point out that when we're developing these models, you can do lots of different statistical analysis to show how good the models are. But it is, at the end of the day, an estimation. It's not an individual value. This is, at best, an estimation. And you are seeing how close you as an individual fit to that estimation. But the thing that I think you can also see from the outset is that this algorithm is also going to be based on a single approach to a compartmentalized model. It can't apply to 3 different things at the same time because it is a unifying approach. There are various models available, some commercial, for population PK. It is argued that different products may behave differently and require different individual population PK curves. We don't actually know, but there's a group in Canada with Alfonso Irorio who's trying to answer a lot of these questions through what's called the WAPS network, where people supply data on patients and the population PK is calculated and the algorithms are improved. So it's a very important piece of work because population PK is simple, it's popular, but there are a lot of questions that we still need to answer about it. Aside from getting the individual data, population PK also allows us to draw essentially things like centile charts, which you see for growth. We can work out what the mean is, and then we can work out centile variation around it. So that is quite useful when you're thinking about how somebody is likely to behave in terms of what's the likelihood in regime A, at dose A, of achieving a level of greater than 1 at 7 days. You know that 95% of your patients will achieve that at that dosing. So you can work out these sort of things with different doses. So that's quite an interesting approach. So to summarise, individual PK is probably more precise, it's certainly more time consuming and more demanding, but it is personalised. Population PKs are going to be simpler, much simpler to perform. They do require population data to compile it, and it is an assumption because it's a model. We don't know whether they're all product specific, but we sort of feel that they're probably not. And the centile approach may be useful as a starting point to pick doses with various products because you can get a rough estimation of how likely you are to be at such and such a point with 50% of your population. That's all very well, though, when we're talking about half-lives. And I'd just like to throw this into the mess that pharmacokinetics can provide more than just half-life. Here we have 2 products, A and B. Product B has a longer half-life than, a shorter half-life than product A by calculation. But what you can see is that the area under the curve for B is greater than A. And so from a haemophilia point of view, the value of B may be greater than the value of A in terms of bleed protection. And that's because the clearance of B is less than the clearance of A. Now I bring this up because everybody historically talks about half-life, and we hear a lot about half-life and extended half-lives and so on. But there is a lot that you will start to hear about how clearance may be more relevant as a marker of efficacy and potential efficacy. So it's to flag it up, and this is the reason why, that people are starting to talk about clearance as well as half-life. Now, let's think about extended half-life products. I suspect I've muddied the waters a lot already in terms of of the standard half-life products and talking about outliers and variation around the mean. With extended half-life products, what we've got is a half-life that varies, and you've got a range of treatment interval. With an extended half-life product, stylized, that is going to potentially increase because the longer is going to get longer still, and the shorter ones are going to get longer, but the range now in terms of treatment is potentially really quite large. So arguably one size is even less likely to be necessarily perfectly applicable with extended half-life therapies. And in fact, if you look at some of the centile type charts that we've produced for extended half-life products, you can see how wide the spread is for various dosing regimes at fixed points. So we can see here that at 5 days, with 50 units per kilo of an extended half-life factor 8, the mean is 1%. But you can also see that a significant number of patients here are going to be lying at around 10%. So really quite significant variation. When we start to put this in context, I think we can see how one size can't necessarily fit all when you start to think about these different things. A child that's out playing sports every day or every other day, what do they actually need? Do they need the peak or do they need the trough? Somebody who goes out and gets blitzed on a Friday night, that's the time you need to have the treatment rather than necessarily working to other treatments. Sedentary office workers, they could get away with relatively low frequency treatments because you're just trying to maintain the lower levels. And so you've got all these various different examples that you consider, but I think it's important to start to think about how you need to probably, with the newer therapies, have some basis on which you choose your regime. So where are we headed? The principle, I hope I've explained, and certainly I believe that it's the way forward, and we're trying to do that in our own centre. But I think it's going to come now and face us all, because we know from the NHSE commissioning documents for factor concentrates, for extended half-life blood products, that we need to have reference to pharmacokinetics and the difference between the two so that we can actually produce a treatment regime that makes sense. Now, a lot of this is going to be focused around saving money, but the principle is there, that pharmacokinetics are increasingly going to become important. And this is important because it means that when we start thinking about how we can treat patients, at the moment we treat them, say, every alternate day. With extended half-life treatments, we could achieve that less frequently. Or we could give it with the same frequency and a lot less to achieve the same aim, or, I suspect as a lot of us might like to do, treat pretty frequently and really drive up that trough level. Or for many patients, you're going to have the opportunity of doing something in between. It's only by knowing the individual pharmacokinetics, or at least thinking about it, at the very least, that gives you the best estimate of what you can achieve for your patients. I think it could improve the quality of life for patients because you're going to address their personal choices, their treatment burden, and also what you're trying to achieve. And one size probably no longer does fit all for all the reasons that we've said here. So I think there is an increasing argument for tailoring treatment to the individual, that PK parameters are not just helpful, they're going to become increasingly required to adjust treatment and individualize it logically, because PK adjustment is rational. And though individual PKs are probably more precise, they're more difficult, and we probably are going to think about population PK. There is, and I'm not going to talk about it, data that shows that if you do PK adjust treatment, not only can you get the outcomes, you can reduce your product use and optimize treatment. Patient adherence, interestingly, if you population PK and individualize treatment and discuss it with the patients, is often better because they are part of the decision-making process, because they're engaged. So, in summary, I don't think one size is going to fit all. increasingly so. We're starting that journey now, and I think it's just going to continue. But I think there is a logic to move away from just thinking that everybody needs to be treated every alternate day. So I'll leave it at that.